Hello, this is the P2 Network Meet the Expert series. My name is Jeffrey Neal, and together with my colleague, Dr. Andrew Miller, we're going to focus on cardiac tamponade and pericardiocentesis. We are both POCUS fellowship-trained pediatric emergency medicine physicians at Boston Children's Hospital. So overall, we're going to do a brief review of cardiac scanning, but as this has been reviewed in a previous lecture in the core content series, we will not go into depth here. The goals and objectives are listed below, and we'll focus on the scenarios to consider cardiac tamponade, the typical probe and images required with this diagnosis, a brief review of normal anatomy as well as pathology, and a brief review of the pericardiocentesis procedure. In regards to the indications for cardiac tamponade, they're based off of history and clinical presentation. So if you have a patient in shock, cardiac tamponade should always be considered, particularly if there's a history of infection, severe renal disease, malignancy, autoimmune disease, heart failure, or recent MI. Other indications you might consider this diagnosis include chest pain, shortness of breath, trauma, an indwelling central line, or a recent cardiothoracic surgery or procedure. When selecting a probe for pericardial effusions or tamponade, most of us choose, not surprisingly, the cardiac or phased array probe. It's a low-frequency probe that allows for good penetration and also a small footprint to navigate those tiny rib spaces in children. Most machines will already have the preset settings for cardiac exams, but if not available, you want to make sure you optimize gain and depth. And generally in children, you'll need less depth for the peristernal views and more depth for the subxiphoid and apical four-chamber views. Alternative probes, you could consider the curvilinear probe, but this is a wider footprint and doesn't always allow you to navigate in between those rib spaces. As this has been reviewed in the previous lectures, we're not going to intensely review these here, but the four standard cardiac views obtained are the peristernal long, peristernal short, apical four-chamber, and subxiphoid. The IVC view can also be particularly helpful for confirmation of tamponade. As you see, the four most helpful probe positions are labeled here. As most of you are experienced, we will not again review this in detail. Obtaining an IVC view can be particularly helpful to determine if there's any respiro-phasic variation in the size of the IVC. We will now review some clips of normal anatomy, focusing on the views that might be helpful for evaluation in children with cardiac tamponade. The structures you want to focus on for the peristernal long views include the right side of the heart, where you have the right ventricular outflow tract, and the mitral valve, as well as these structures can be helpful in evaluating for right-sided diastolic collapse. This is the apical four-chamber view, which is helpful to evaluate for right-sided diastolic collapse, as it affords great view of the valves when they're opened and closed. Finally, this is the subxiphoid view, which can be also helpful for excellent views of the right ventricle in relation to the positioning of the valves. We will now review some clips that demonstrate a large effusion with sonographic findings consistent with tamponade. Although cardiac tamponade is largely a clinical diagnosis, there are some sonographic findings that are suggestive of tamponade physiology. The two most common are right atrial and right ventricular collapse, which you need to see during diastole when the valves are closed. You may also see signs of pulsus paradoxus, which we will talk about on another slide, or a plethoric IVC with limited respiro-phasic variation. Here you can see a moderately sized pericardial effusion on the peristernal long view, and despite the size, we do not appreciate any significant right-sided collapse. When switching to the subxiphoid view, you do appreciate collapse of the right ventricle, but when you slow this down, the collapse is primarily when the tricuspid valve is closed or during systole, so this would not be consistent with cardiac tamponade physiology. We can also discuss the concept of sonographic pulsus paradoxus, which uses mitral valve inflow velocities to detect the respiro-phasic variation seen in tamponade. Usually done in the apical four-chamber view, although this is a peristernal long view here, you can use pulse wave Doppler through the mitral valve or the tricuspid valve. Sorry about that. And what you want to look at is the E wave and A waves, and the difference between the highest E wave and the lowest E wave, which corresponds to inspiration versus expiration, can help you determine if sonographic pulsus paradoxus is present. Here you can see the difference between the highest peak and the lowest peak is 27%. And usually if they're more than 25%, that's an abnormal variation, and more than 40% with the tricuspid valve, that's an abnormal variation consistent with sonographic pulsus paradoxus. Finally, another sonographic finding that can support the diagnosis of tamponade would be a plethoric IVC, which is seen here with limited variation during respiration, and a collapsing IVC here, which is not supportive of a diagnosis of tamponade.
Thank you, Jeff. So now we're going to speak about the procedure of the pericardiocentesis. While this is less common in the pediatric emergency department setting, we will discuss this as it is important and life-saving. So in terms of the emergent indications and contraindications, we will review that the indications represent you will only do this in the emergent setting when there is life-threatening hemodynamic compromise in the setting of a pericardial effusion. And Dr. Neal just mentioned all of the ultrasonographic findings related to cardiac tamponade, which can assist you. However, should also base this on the clinical presentation, specifically the patient's hemodynamics. I give a caveat to this is that this should also be done in the setting of if you are in a hospital in which you have urgent availability of an additional provider, such as a interventional cardiologist or others. You may consider doing other medical management, such as rapid fluid administration, et cetera, to bridge you to the point of getting to a OR or other more controlled setting than done in the emergency department. However, much more the bread and butter of the pediatric emergency department setting is when there's a cardiac arrest with pericardial effusion, in which this can be a life-saving intervention to achieve ROSC. With regards to the contraindications, we are really talking about the emergent indications and contraindications of a pericardiocentesis, which in the emergent setting, there are no true contraindications. There are some relative contraindications, which you should consider related to bleeding diathesis, aortic dissection, or myocardial rupture. However, in the emergent setting, these are relative and not true contraindications. With regards to the equipment, some facilities may have a separate pericardiocentesis kit. You also need an ultrasound machine, as well as sterile gloves, gown, drape, and other sterile equipment. With regards to the emergent indications for this, some of this may not be necessary, such as draping in full gowns, and you may opt to put on sterile gloves and perform the procedure in the setting of an arrest. If you do not have a pericardiocentesis kit, you can make your own kit, which is simply a spinal needle. Approximately an 18 gauge needle is typically the size that is used. The sizing here in this picture shows two sizes, one smaller and one larger needle. The larger needle would be for a larger obese adolescent. However, the smaller needle can be used for a younger child or of a smaller body habitus. You also need a 30 cc syringe. Some people also quote the use of a 20 cc syringe. What you really need is something small enough to fit in your hand and not too cumbersome, such as a 60 cc syringe. You need a 3-way stopcock and then some chlorhexidine to quickly clean the skin, as well as an ultrasound machine and the sterile equipment as detailed previously. The equipment can then be placed together by putting the spinal needle attached to the 3-way stopcock, then attached to the syringe seen here in the bottom of the screen. The 3-way stopcock is simply used that if you take out more than the syringe can handle, such as this syringe being a 30 cc syringe, you can essentially remove that without actually moving the needle by opening up the 3-way stopcock, releasing that fluid from the syringe, and then closing it to the output and drawing out more fluid. The probes that can be used, as Dr. Neal had already mentioned, the phased array probe is the common probe that is used in the setting of evaluating cardiac POCUS. However, The phased array probe has some limitations related to finding the needle itself on the image. Therefore, the curvilinear and linear probe are also used in the setting of the pericardiocentesis procedure. It just depends on your ability to see based on the child's landmarks and anatomy, as well as your preference for location, which we will talk about in the next slides. So what is discussed frequently is the subxiphoid approach, which you can see on the left side of the screen as an image showing a subxiphoid pericardial fusion. However, on the right side of the screen, you can see a peristernal long axis view showing a circumferential pericardial fusion. And the goal of this is to essentially approach the patient and the procedure in which you can best access the fluid that is seen on your patient. So the landmarks in which we will show here are the initial landmarks related to the subxiphoid approach, which on the green circle, you can see that's the subxiphoid process. And then showing the patient's left shoulder with the other green circle. And what you will do is place the probe in the subxiphoid region. And the blue arrow represents the approach of the needle pointing towards the left shoulder. This can all be done under ultrasound guidance. Another approach would be the peristernal approach, which you typically perform in the peristernal region, similar to where you would approach peristernal views on cardiac POCUS, which has been previously discussed. However, you will go perpendicular to the skin and in the fifth intercostal space typically, but again, going where the fluid is to access the subxiphoid process is shown here. As you can see, this patient is not an extremis and is just a model. Zooming in on the needle, you can see that you place the needle directly next to the probe, and you can use the probe to guide the needle to the fluid itself. The peristernal approach is shown here as well, in which you place the needle perpendicular to the skin and advance in the peristernal region to access the fluid. This is a zoomed in view of this. This is an actual pericardiocentesis performed in the setting of a patient who underwent resuscitation, ultimately having cardiac arrest. And you can see on the right side of the screen in this subcostal view that the needle comes in, enters the pericardial space. And with this patient's outcome was that they were able to achieve ROSC. However, the patient ultimately expired.
We will now talk about some pearls and pitfalls of scanning for tamponade. So remember that overall, we are looking for diastolic collapse of either the right atria or the right ventricle. And if having trouble confirming collapses in diastole, you can use M mode to confirm the E wave and movement of the mitral valve. Ultrasound should be used to support your diagnosis of tamponade, as the physical exam findings of Beck's triad typically lack specificity and sensitivity. And as with any application in ultrasound, the limitation lies in the user and cooperativity of our patients to sit still for these exams. We're now going to walk through an illustrative case. This is a case I had in, I believe, my first year of fellowship, where we encountered a 16-year-old male with a past medical history of a bicommissural aortic valve who came to the emergency department with 3 months of intermittent episodes of chest pain, emesis, and low-grade fevers. On physical exam, his vital signs were unremarkable. He was a well-appearing, thin young male with no signs of respiratory distress. The only pertinent finding was some slightly distended neck veins. A chest radiograph was taken, which demonstrated a significantly enlarged cardiac silhouette, as you can see here. So then we proceeded quickly by putting a probe on the patient. And as you can see in the peristernal view, there's a massive effusion with loculations. And focusing on the right ventricular free wall, you can see evidence of diastolic collapse as the wall collapses down when the mitral valve is open, which is during diastole. This is sometimes referred to as appearing like a man jumping on a trampoline. This is another example of right ventricular free wall collapse as seen here. And you can also, again, confirm collapse by utilizing M mode to plot the motion of both the mitral valve and the ventricular wall over time. Similarly, with our patient in the apical 4 view, you can see collapse of the right-sided structures during diastole, indicating a sonographic diagnosis of tamponade. Ultimately, the patient was admitted upstairs and underwent an emergent pericardiocentesis with drain placement with a removal of around 1,350 cc's of serosanguinous fluid by interventional cardiology. All of his gram stain culture and cytology were negative, and despite a thorough infectious workup, the etiology of his infusion was ultimately idiopathic. So overall, in terms of our key take-home points for this lecture, certain sonographic findings can be supportive of a diagnosis of tamponade. So remember, right atrial and right ventricular collapse is the most important. We discussed also evaluating for sonographic pulsus paradoxus, as well as the plethoric IVC to support your sonographic diagnosis of tamponade. Dr. Miller talked about pericardiocentesis and also discussed the importance of really performing this in the setting of true tamponade or cardiac arrest. If the patient is stable vital signs, not an extremis, most likely this can wait until the patient is in an area such as the ICU or interventional cardiology or radiology can assist with the procedure. And the approach should be based on fluid location, either the subxiphoid or peristernal access view. Thank you very much for listening to this lecture. We're now going to show you just some information about both of us. If you have any questions, feel free to contact the P2 network or either of us.